Hi, this is Bob Harrington from Stanford University on Medscape Cardiology and theheart.org. One of the topics that has come up in a number of forums over the course of our discussions in the last year has been around the VA healthcare system, the U.S. Department of Veterans Affairs. And much of what we read in the lay press tends to criticize the VA healthcare system for lack of timeliness of care, some of the challenges with access. But many of us who work in the cardiology arena have a very different experience with the VA healthcare system, and that is a very positive experience. The VA healthcare system serves as a model for the tripartite mission of academic medicine, where outstanding clinical care being delivered to our veterans, research being performed within that system, both basic and clinical, as well as outstanding training programs across the VA system. So we thought it might be useful to have a conversation with two national leaders in VA cardiology to really help understand some of the issues of delivering health care to our veterans, doing research in that system, and maybe even delve into some of the policy issues around things like a single electronic health record across an entire country. So I'm pleased to be joined today by two colleagues. First is longtime friend and colleague Sunil Rao, who is the section chief of cardiology at the Durham VA Medical Center in Durham, North Carolina. Sunil is also an associate professor of medicine at Duke University. Welcome, Sunil, to theheart.org.
Thanks so much for having me, Bob.
And our second guest is Rich Schofield, who is the National Program Director of Cardiology in the Office of Specialty Care in the U.S. Department of Veterans Affairs. Rich is also a professor of medicine at the University of Florida. Rich, thanks for joining us here on theheart.org and Medscape Cardiology.
Thanks, Bob. It's a pleasure to be with you.
So maybe, Rich, we'll jump first from a national perspective, and then we'll pull Sunil into the conversation as we start dealing maybe with some of the more specific questions. Help our listeners and readers understand, how is the VA healthcare system organized? Maybe you could start broadly with how it's organized across the entire system, and then talk specifically about how cardiology is organized. And then I'll start pulling some questions in from you around what your specific role as the program director is.
Sure, Bob. I'd be happy to do that. The VA is organized around regional networks that are called Veteran Integrated Service Networks, or VISNs. Historically, there have been 23 VISNs around the United States, and within these VISNs are 152 inpatient medical centers, about 1,500 outpatient clinics, and really the entire country is covered by these facilities, which makes it the largest integrated healthcare system in the United States. Now, within the VA, there's currently about 650 FTE dedicated to cardiologists, but because some of the cardiologists have part-time positions in the VA, the actual number of cardiology physicians is closer to about 900 right now. In addition, there's about 300 advanced practice providers, either nurse practitioners or physician assistants, that are dedicated towards cardiology. So this is a pretty big organization, and cardiology is a particularly strong entity within the VA.
Talk to me, Rich, about the role that you play as the National Program Director. How does that play out? What are you responsible for? What are you accountable for? What reports up to you? And what stays at the level of the local veterans hospital? Then I'll pull Sunil in for some insights from the Durham VA.
Sure. The individual medical centers all report up to their chain of command through the VISN leadership and then to the VA central office. For day-to-day operational type issues, that would be the reporting structure. My role is under the VA Undersecretary for Policy and Services. So in that role, I would be the chief consultant for cardiology, which would be the point person for VA senior leadership for cardiology-specific issues, or for clinical or quality of care concerns that can't be resolved at the local level. Those might be elevated to me as the National Program Director. I also have oversight over the National Cardiology Device Surveillance Program, which is a really unique and state-of-the-art surveillance program for VA patients with implanted pacemakers or defibrillators. We have two sites that monitor currently over 40,000 patients with implanted devices. Likewise, I'd be a key interface for VA senior leadership with the VA CART program. CART is our cath lab clinical quality data registry, which is a really unique and also innovative state-of-the-art program that was initiated more than a decade ago and captures all of our cath lab diagnostic or interventional coronary procedures at the point of care using information that's input by clinicians at the time of performing cath lab procedures. So these are some of the things that would be within my purview as a national program director, and it gives you some idea of the breadth of the division.
Yeah, it's an extraordinary breadth when you think about the number of patients you touch, the number of procedures performed, and the number of providers involved in the whole system. So your job of having a national policy level position is a critically important one to keep the whole machine running. Sunil, let's jump down to the local level. Rich is talking the big picture. Talk about how cardiology care is actualized at the local level. You're the section chief of the Durham VA Medical Center, which is a close partner with Duke University. Actually, Duke University Medical Center is right across the street from the Durham VA. And those relationships between a veterans hospital and a university can be very close ones across the country. Certainly it is in Durham. Certainly it is here in Palo Alto at Stanford, where I work. And I'm wondering if you can take some of Rich's broad national comments and bring it down to the local level. How's cardiology care actually delivered at the local level in the VA? How much autonomy do you have? How much do you follow policy? How much do you feel part of an integrated healthcare system?
Rich can correct me. I think there are like 117 VA facilities that are affiliated with academic centers. There are two parts of the question. How do we integrate with the academic program is the first part of it, and second, how do we actually deliver care and manage patients here at the local level? The first part is that I think the VA is an integral part of the training program for the medical students and the house staff at Duke University, and I'm sure that's true for other VAs that have academic partners. It's the place where medical students and house staff really can learn how to do both general medicine care as well as subspecialty care, working very, very closely with local and national experts. The VA facilities tend to be, on average, smaller than larger academic facilities, so there's a lot more one-on-one interaction between the attending level physician and the student or the resident or the fellow. From a hospital level perspective, we have the same goal as any other hospital or health system, which is to treat the largest number of veterans with the highest quality care at the lowest cost. And we've been very lucky here in Durham with outstanding hospital leadership that has been very much a good partner with the physicians on bringing the latest technologies to veterans, whether that's interventional technologies, the latest medications. There's also, when you talk about the integration, it's important to mention the electronic health record, which is really part and parcel of how we protocolize care. CPRS is one of the first electronic health records that was ever introduced. It was introduced when I was an intern in 1996, 1997, at least here in Durham. And it is the same electronic health record that all VA facilities use. You may have seen today in the Wall Street Journal there's an editorial about the lack of interoperability for private sector electronic health records and how that's been frustrating to clinicians. We don't deal with that in the VA because if a veteran gets care at Rich's VA and they come to Durham, I have access to their records through a very, very fast internet link. I can see everything that's occurred at that other facility. And the great thing about CPRS is that it is very malleable at the local level. So, for example, when we introduced a new program here in Durham for same-day discharge after elective PCI, we constructed our post-PCI visit note so that we could go back as part of QI and mine the data just to see what the outcomes were so that we could inform our own practice. And CPRS is very malleable that way. We can set it up very, very quickly just through our local IT folks. We'll probably get to this a little later in the conversation, but CPRS has also now become a very powerful tool for clinical research with randomization modules that are now available, and people can randomize through CPRS and do follow-up through CPRS. The VA CART program that Rich mentioned for cath labs is similar to NCDR in the sense that it is a QI initiative. It's different because the data are entered at the point of care. So NCDR, oftentimes the data are sort of dumped into the database on a quarterly basis or on a monthly basis. What we're doing is at the point of care, after we do the procedure, we document the procedure, the data are automatically entered into the database almost immediately. And so it's an ongoing way of being able to track the quality of care that veterans are getting who are coming through the cath lab. A couple of unique things about the VA CART program, and Rich can talk more about this, is that we have a very robust major adverse event screening process. So any adverse event that occurs in the cath lab is immediately reviewed by the Major Adverse Event Committee, particularly in hospital strokes and deaths, for example, or in lab strokes and deaths. There's also a unique feature of VA CART. It's a field that was added when the database was first conceived, which is a field that's titled Unexpected Problems with Device. So this is a way of collecting real-world, real-time data, almost in a post-marketing surveillance kind of context, where devices that we're using in the cath lab, if there's some untoward event that's unexpected, we can report that through VA CART, and those data can be captured and reported at a later date.
So, that's a terrific overview. I did see the Wall Street Journal article, and in preparation for this discussion today, it did make me think about the benefit, really, of a true interoperable electronic health record. I've often lamented if I, as a non-veteran, have a heart attack while I'm visiting Durham, nobody can access my records from Stanford without great difficulty. But if I happen to be a veteran and had that same heart attack while I was visiting Durham, you can get the data from the Palo Alto VA immediately. And boy, what an advantage that is, along with all my prescription data, my current medication use, et cetera. I mean, it's really fantastic. Rich, I want to explore this a little deeper because it seems to me that the single EHR allows you as a national leader to do the things that any leader of a healthcare system or program wants to do. You want to look at the quality of care that's being delivered, the consistency. You want to understand not just your clinical drivers, but your cost drivers, all of that. Talk to the audience about the balance of culture and technology and the issue of top-down insistence on using a single EHR versus things bubbling up. And as Sunil said, how do you balance the local desires against national need? Can you give us some sense of culture and technology?
I would say there is some ability to modify certain things at the local level. Things like note templates can be modified. There's tremendous advantages to working with the local clinical informatics team at individual VAs. Typically, these are nurses with training in clinical informatics, and they can be quite helpful in designing local quality improvement initiatives, much as Sunil had mentioned. The other thing, Bob, that I think is sometimes lost for folks that have not worked in a healthcare system that's really completely integrated is a tremendous advantage for just day in, day out clinical care. My interest is in heart failure management, and we have a really robust heart failure clinic here at our local VA, and it's very easy for me to make medication adjustments on my heart failure patients and order lab work, for instance, at a outlying VA clinic, maybe 100 miles or 200 miles away, for the patient to be seen for lab work within 24, 48 hours of a medication change. And I can't do that in my academic practice. Oftentimes I have to negotiate with different insurers, or the patient has to go to separate healthcare facilities to get labs drawn and things like that. And just the ability to coordinate care is so much easier in this system, and I think that's the real advantage.
Yeah, I think about our own situation here at Stanford, where we have two healthcare systems on campus. We have an adult healthcare system and a pediatric healthcare system, and those healthcare systems are actually physically connected. You walk from the hallway of the adult hospital into the pediatric hospital, and yet we use two different versions of Epic, which are not well integrated with one another, and that has to do a lot with the complexity of the business relationships with Epic. So here we have two healthcare systems owned by the same university. They're separate corporate entities, but they're ultimately owned by Stanford, and we have completely non-integrated healthcare record systems, which to me is an extraordinary waste. It's a waste of resources, it's not efficient, and most importantly, it's not good for patient care and quality. I'm really heartened when I think about what's possible. Certainly the VA is what's possible. Sunil, you had made the comment to me that in some cases, technology diffusion in the VA can be more rapid than technology diffusion in less integrated healthcare systems. And the two examples you gave were telemedicine, telehealth, and robotic PCI. You want to comment on that? And then I'll ask Rich's perspective at the national level, how he thinks about technology diffusion.
Yeah, sure. This is a great example of how necessity is the mother of invention. The VA, despite its size and scope, has limited real estate space. We're not going to be building a lot of new buildings over the next several years very, very quickly. But the needs for patients don't stop there. And so, for example, what the VA has embraced wholeheartedly is telehealth. We know that cardiac patients are underprescribed cardiac rehabilitation. Cardiac rehabilitation facilities are limited within the VA system, and so we've had to rely oftentimes on outside facilities to provide cardiac rehab services, and there sometimes can be a delay in getting the patients to those facilities. So the VA has invested now in telehealth programs. Rich has one in his facility. We're just starting ours. The VA has provided us with some grant funding to get this going. And it's home-based cardiac rehab through a telehealth program. So when patients come in with acute coronary syndrome, or even if they have undergo PCI or they're admitted with heart failure, they will have an evaluation and get an exercise prescription before they go home. They're supplied with an iPad-like device that allows a nurse practitioner or a nurse to interface with them live through a video link every week to follow along and see how they're adhering to their exercise prescription and if they have any issues with it. They're provided with exercise equipment. This is all free for the patients. And they can do their cardiac rehabilitation at home with monitoring from the central facility. And that's a way we're bringing technology to provide care to veterans so it's close to home. They don't have to drive to a cardiac rehabilitation facility. They don't have to drive back to the VA. Many of the veterans live far away. We're going to measure the outcomes from that. So this is really an important way that the VA is adopting technology. Other ways is that, my experience is obviously through the cath lab, and we were very early adopters of integrated IVUS imaging. We were very early adopters of automated contrast injection. We're the first hospital in our area to have robotic PCI. Sometimes, as you know, Bob, it can be easier to work in a system if you have partnership with leadership that keeps their eye on the ball and says, what are we trying to do here? We're trying to provide the best services for the veterans. We're going to rely on the clinicians to make those decisions. You can really get new technologies and new strategies much, much quicker if you've got a partnership like that.
That's well described. One of the things that's always impressed me in talking to my colleagues in the veteran system is this sense of mission. You've indicated it's to provide care for the veterans and provide high quality of care for our veterans. Rich, you want to talk about technology diffusion at the national level, how you think about it? Are there places around the country that you guys look at as beta sites for some of these technologies? Are you more likely to roll it out to a few places? How do you think about it?
I would say that the new technologies, especially if they're procedural-based technologies, tend to roll out more at our larger facilities. We call those the 1A facilities. Those are more high-complexity VAs. Almost always, these are sites that are affiliated with major university medical centers. But we've been quite fortunate to integrate a number of innovative new technologies in cardiology. TAVR is an example. It currently is active at 8 different sites around the VA, and we think there are about 20 sites that should be coming online with TAVR in the next year or so. There are about 15 VA sites right now have begun implanting the PA pressure monitoring sensor called the CardioMEMS device. We think that is a particularly appealing device for rollout in the VA system because we have such good integration of care in our heart failure clinics. And we think they can take full advantage of the hemodynamic information from that device to help reduce heart failure hospitalizations. Sunil has already mentioned cardiac rehab. We don't have a lot of in-facility cardiac rehab programs, but through some generous grants through the VA Office of Rural Health, there are a number of programs that are now opening up cardiac rehab that is using telemedicine techniques to do in-home cardiac rehab with coaching of the patients to help them to exercise at home. So these are just some advantages of the system, Bob, and I think there are other technologies that we hope to roll out in the near future. The mitral clip device is one that's particularly high on our list, as is the Watchman left atrial occlusion device.
Yeah, it really has struck me as, again, pointing out the advantages of a large integrated system where decisions can be made about what things are appropriate in what settings. And both of you have indicated this, but I'll give you both a chance to comment on it. Your electronic health record and some of your quality systems that are in place provide an opportunity not just for quality improvement initiatives, but also a chance to do research. And some of the work that the VA is doing for example, in point-of-care randomization, in pragmatic trials, the hypertension trial with the two different diuretics comes to mind. I find it an extraordinary opportunity for the rest of the country to really learn from. I'm wondering if you close, both of you, and I'll start with you, Sunil. Can you comment on what you see as the real strengths of the VA research system, and then maybe just a brief comment on what your hopes are for the future in the VA, maybe talking specifically, Sunil, from the local level, then I'll turn it over to you, Rich, for the national perspective. So, Sunil?
Sure. Yeah, I think the strengths of the VA system are the fact that we have this electronic health record that's integrated. Also, veterans tend to come back to the VA, so we have really close follow-up of the patients that we put into studies. In addition, because VA hospitals in general tend to be smaller than larger health systems, we're able to pick and choose our studies very carefully, and we tend to perform very, very well as clinical sites for clinical trials. Honestly, I think the biggest strength that we have in the VA nationally in cardiology is that we have this really terrific culture of collaboration. There is a group of cardiologists throughout the VA system who work closely together. We're good friends. We have similar interests. We're interested in staying in the VA system. We're interested in making sure the VA system succeeds. We have terrific leadership both at the local and the national level with Rich, who supports early career investigators and clinicians in the VA system. And that's really the strength. I think it's this culture of wanting to make the system succeed. And my hope for the future is that that continues. We have a lot of people who are coming out of training who are wanting to go work in the VA system to start their careers. And I think that as long as we keep up that generational interest in working in the VA system, I think that cardiology has a very bright future in the VA.
Well said. Rich, you want to give us, in closing, your thoughts on the national scene?
Yeah, Bob, there are a number of tremendous advantages to doing clinical research in the VA. We've already mentioned the electronic health record, which is a big advantage. Another important linkage is the fact that VA undertook a number of years ago a really groundbreaking initiative called the Million Veterans Program. That's an initiative to collect blood samples on 1 million patients and to link the genotype information from those blood samples to 40 years of continuous phenotypic information from the electronic health record. And cardiology has a key role to play in that, and we have a number of really bright investigators that are working with the Million Veterans Program. I would also point out the advantages of the VA Cooperative Studies Program. The cooperative studies are usually sort of medium-sized clinical trials where the clinical question can be answered usually with 500, 600, 700 patients. Those VA cooperative studies have been enormously successful in the area of cardiology. And Bob, I'm sure you're familiar with some of the older VA cooperative studies, many of which were pivotal in cardiovascular disease, acute coronary syndromes, et cetera. One in particular that I think has a really bright promise is the VA cooperative study on ICD implantation in the elderly. As you know, the primary prevention implantation of ICDs, the early studies included very few patients that were elderly, yet in clinical practice, many of the patients that would qualify for these devices are quite old. Some important questions to be answered there. Our cardiac electrophysiologists are helping to lead a really important study on ICD implantation in the elderly. That's just a couple of examples. There are many others, and I think the clinical trials possibilities within the VA is really tremendous.
I want to thank both of you. This has been a terrific discussion around what's possible for clinical care, for teaching, for research in a large integrated healthcare system, in this case, the Veterans Healthcare System. I want to thank my two guests today, Rich Schofield, who's the National Program Director of Cardiology in the U.S. Department of Veterans Affairs and a professor of medicine in cardiology at the University of Florida, and my colleague, Sunil Rao, who is the Section Chief in Cardiology at the Durham VA Medical Center and Associate Professor of Medicine at Duke University. Rich and Sunil, thanks for joining us here on Medscape Cardiology.